Hey everyone, welcome back to Hands-On Skills. My name is Alex Like, and in today's lecture we're going to be talking about placement of the Laryngeal Mask Airway, or the LMA. Much like our combi tube, our king airway, and our eye gels, LMAs are considered supraglottic airways. And what this means is the airway doesn't actually sit inside the larynx. It sits in the space right before the laryngeal inlet, sort of in that low hypopharynx and that low oropharynx space. So this is something that can be inserted blindly. You don't need any sort of fancy intubation equipment like a laryngoscope or anything like that. And because it can be inserted blindly, there's very little training involved in its insertion, and it can be inserted pretty quickly, usually in about 30 seconds or so with a well-trained provider. Now, the nice thing about the LMA, just like with your king airways, it can be used with pediatric and adult patients. There are 7 sizes available, but unlike things like the king airway, the LMA is sized based on the patient's weight in kilograms. So you do have to kind of guesstimate a metric weight for your patients when you use this or when you choose a size. These are really reliable devices. They have a very long track record of success, particularly in the operating theaters or in the ORs. Very, very fond of them there. We're also very fond of them in the emergency department. We use them a lot as a good backup airway. And they're very, very inexpensive too. So unlike the eye gels, which are relatively new to the marketplace, the LMAs have been around so long that they're relatively inexpensive. So it's a very good choice for your backup supraglottic airway in lieu of the king. Here's a size chart, basically letting you know what size LMA you would choose based on the patient's weight. Again, remember, this is determined based on your patient's weight in kilograms. So kilogram weight, which is sort of in this column here, will let you know what size LMA you need to choose. Most adults are going to be between a size 3 and a 4. Female adult patients are usually about a size 3. Most average adult male patients usually take about a size 4, but you do have options here. Now, on the right side of this chart, there is a column that says largest ET tube in millimeters. What this is referring to is there are certain types of LMAs that actually allow the passage of an ET tube through the device directly into the larynx. So you can actually intubate through some of the models of the LMA. And this chart, this column here on the right, will let you know what is the absolute maximum size ET tube you can put through the LMA that you've already placed in the patient. So a lot of uses for this device here. What you're seeing here is a picture of a typical LMA. This is the kind that you cannot intubate through, and I'll show you why in a second here. It's a pretty distinctive looking device. I think it reminds me of the shape of a tulip before it blooms. So let's kind of break it down piece by piece here. So on the far left side of your screen, you're seeing the cuff here. The cuff is what actually will seat sort of around that laryngeal inlet space. Also, just to give you a quick heads up, you're looking at the device as it would be placed in the patient. So this would be facing anteriorly, directed toward the airway. On the back side, as you'll see in the actual insertion video, it's flat. So this is directing airflow at the patient's larynx, the way it's positioned currently. So these aperture bars here on the inside of the mask itself actually prevent the device from sort of collapsing or folding in on itself, compromising that airflow. So they're there as structural support and also keep the plastic membrane of the inside of the mask open. Next to the aperture bars here in the picture is the valve. This is where you connect your syringe to inflate the device. Your pilot balloon, which offers you the chance to assure that your mask is still inflated once the device is in the patient. The pilot balloon stays inflated if the mask is inflated. And obviously I can't check the patency of the mask if it's already in the patient, so I can kind of squeeze the pilot balloon to see if there's air pressure in it still. And this is true with all of your airway devices. Once that distal cuff disappears, all you're left with is the pilot balloon to assure that you've still got pressure in that cuff. So it's very important to check the patency of that too. Connecting the pilot balloon to the actual mask itself is your inflation line. Just be careful with your trauma shears or any sharp objects around this. If you cut the inflation line, the entire mask will deflate. On the right side is your standard airway connector flange. This connects to BBMs. Fortunately, that fitment is one size, so all of your airway connector flanges are interchangeable with various size BVMs or ventilator attachments. You've got your airway tube, and this will change in length dependent on the size of the LMA that you're choosing. And then of course your mask, which will also be larger or smaller depending on what size LMA you are putting in this patient. The picture you're seeing here is a cross section of what the LMA looks like when it's already inserted into a patient. As you'll notice, the LMA is not in the trachea. The trachea is here. The LMA is sitting in the space immediately proximal to that. So it's directing airflow at the trachea. So this is great for patients who don't have anything like laryngospasms or foreign body airway obstructions, because you're simply protecting the airway from gastric contents coming up to some extent, and then from erroneous airflow entering the mouth. So this is directed at that tracheal space into the windpipe. And once you inflate the mask, it kind of seals the area around it and provides a little bit of protection. So let's take a look and see how we place it. The first thing you want to do here is check responsiveness. Once you know they're unresponsive, you're going to go ahead and size and place an OPA. Now notice how I'm measuring from the corner of the mouth to the tip of the earlobe, and I'll insert it here with just a standard tongue depressor. Once the OPA is in, I'll begin ventilating with the BVM. One breath every 5 to 6 seconds. And I'll go ahead and connect this to oxygen and make sure the patient is on a pulse oximeter. I'll then pass this off to a partner who will continue ventilating while I check my equipment. Now I'll be using a LMA here. This is a size 5 LMA, which means it will take approximately 30 to 40 mLs to inflate the cuff and the pilot balloon. Test the patency of the cuff, make sure there are no leaks. And make sure to apply a ton of lubricant to the backside. Once you're ready, remove your OPA. Coming in midline, use the roof of the mouth as a guide and slide the LMA back until it seats firmly over the larynx. Inflate your cuff. Attach your BVM and begin ventilating. Auscultate all 4 fields of the lungs. And over the epigastrium, making sure there's no gurgling heard over the stomach. You can attach end-tidal CO2 here as well, and we're looking for numbers of 35 to 45 millimeters of mercury. Check your tube depth insertion at the teeth. And once you're sure everything is in place, go ahead and apply a tube holder to secure it in place. The tube is secured. All right, everyone, that was Hands-On Skills LMA placement. I hope you got something out of that video. As always, stay safe and continue washing your hands. I will see you next time.